Hello and welcome again. So after nephritic syndrome, I am taking another very important topic, that is nephrotic syndrome. So again, nephrotic syndrome, it is caused by a variety of primary and secondary glomerular diseases. All those diseases have one thing in common, that is the derangement in the glomerular capillary wall. So the glomerular filtration barrier is defective, and what is the defect? The defect is that it is permeable to the plasma proteins. Normally, the glomerular filtration membrane, it is not permeable to the plasma proteins, but in nephrotic syndrome, there is this defect that there is proteinuria which is occurring, and that is the most important feature of nephrotic syndrome. So, in all the primary and secondary glomerular diseases which are presenting as nephrotic syndrome, the following signs and symptoms, they are common to all of them. So, first and most important is massive proteinuria. So, the proteinuria in nephrotic syndrome, it is known as nephrotic range proteinuria, and you should remember this value. It is very, very important. So, the proteinuria in nephrotic syndrome is more than 3.5 gram per day. So the normal proteinuria, it can be up to 150 milligram per day, but here you can see there is massive proteinuria, and this is nephrotic range proteinuria. So in nephrotic syndrome, when the glomerular damage is limited, like in minimal change disease, the proteinuria is highly selective. So only low molecular weight proteins like albumin, transferrin, they are lost in the urine. But when there will be more glomerular damage, there will be more damage to the glomerular filtration barrier. Then even the high molecular weight proteins like globulins, they are also lost. In that case, it is known as poorly selective proteinuria. So when there is proteinuria, so proteins are lost in the urine, albumin is lost in the urine. So in the blood, there is decrease in the level of the albumins. So there will be hypoalbuminemia. So hypo is decreased albumin concentration in the blood. So the plasma albumin levels, they are less than 3 grams per deciliter. Uh, Now next there will be edema, because when there is decrease in the proteins in the blood, so in the blood vessel there will be decrease in the colloid osmotic pressure because the proteins are lost, they are decreased. So because of that, the fluid will migrate to the extravascular compartment into the interstitial space, that will cause increased edema. So this is another very, very important feature. Next, the liver, it synthesizes more lipoproteins, and because of which there is abnormal transport of the lipids, and there is also there is loss of lipids in the urine. So there is hyperlipidemia and there is lipiduria. So again, these are another important feature of the nephrotic syndrome. So you should remember all these 5 points, which are very important feature of nephrotic syndrome. Next, causes. Again, causes, you have to remember the causes, very often asked in Viva and MCQs. So most common cause of nephrotic syndrome in children is minimal change disease. I will take this in this lecture. And in adults, the most common cause is focal segmental glomerulosclerosis. And in somewhat more older adults, the most common cause is membranous nephropathy. So these are the three are the most important causes which are leading to nephrotic syndrome, and all of these are the primary glomerular diseases. Now this table, it is from the Robbins, and it outlines the important causes of nephrotic syndrome. So they can be primary glomerular diseases, or there can be secondary systemic diseases which are causing nephrotic syndrome. The important primary ones are membranous nephropathy, minimal change disease, then FSGS, uh, and important systemic diseases causing nephrotic syndrome are diabetes, amyloidosis, then SLE. So there can be variety of other causes also, like drugs, infections, then malignant diseases like lymphoma, especially the Hodgkin's lymphoma. Then there are other miscellaneous causes. So you should at least remember the ticked ones. Now we come to the minimal change disease. So in minimal change disease, as the name says, there are minimal changes. On light microscopy, there are very less changes, and also on the immunofluorescence, there are no deposits. So that's why it is called minimal change disease, also known as nil deposit disease. And another name is also lipoid nephrosis. So these are the different names. You should remember these names. And the basic pathology in minimal change disease is there is immune dysfunction. So there are many theories which suggest that there is immune dysfunction in minimal change disease, and that leads to the defect in the podocytes. So there is damage to the podocyte layer, that is visceral epithelial cells, and this that leads to the increased permeability, causing the proteinuria. So they say that in minimal change disease there is immune dysfunction because the minimal change disease is associated with respiratory infections and immunization. Then there is excellent response to the corticosteroids. So it supports the theory that there is a immune mediated damage to the podocytes. And also there is association of this with other atopic disorders. So again, atopy is also a type of immune mediated hypersensitivity reaction, and also there is association of minimal change disease with Hodgkin's lymphoma. So again, Hodgkin lymphoma has an important role of T cell mediated immunity. So again, it supports the theory that there is some immune dysfunction that is leading to the damage to the podocytes, causing the proteinuria in nephrotic syndrome. So you should remember these points, especially this association with Hodgkin's lymphoma. It comes in MCQs. Now next we come to the pathogenesis of nephrotic syndrome. So in nephrotic syndrome, there is basically immune dysfunction, as I already told you, and because of the immune dysfunction there is podocytopathy. So this is the normal glomerular basement glomerular filtration barrier, which has the inner layer of the endothelial cells. Then there is the basement membrane, and then there is the visceral epithelial layer of podocytes. It is called podocyte because there are these food processes. These food processes, they are in opposition with the basement membrane, and it has such architecture that it is negatively charged. So there are negative charges here, and it repels the negatively charged proteins, because proteins, they are also negatively charged, so they are not filtered uh, through the glomerular filtration barrier. But in nephrotic syndrome, there is damage to the podocytes because of the immune dysfunction. So the podocytes, they become effaced like this, and then there is podocyte retraction and damage to the podocytes, and because of which the permeability of the glomerular filtration barrier, it increases, and that causes the proteinuria. So when there is proteinuria, there is because of these damage to the glomerular filtration barrier, the protein molecules, they are filtered in the urine, and they will be heavy proteinuria of more than 3.5 gram per day, and that will lead to, first of all, it will lead to hypoalbuminemia, as the liver will fail to compensate for this loss of protein in the urine. So there is hypoalbuminemia. The albumin levels in the blood, they decrease, and again because of that the colloid osmotic pressure inside the blood vessels, it decreases, and because of that there is the migration of the fluid to the interstitial fluid compartment. So interstitial fluid increases, that causes edema. So the edema in nephrotic syndrome, it is of pitting type, and it is more commonly seen in the periorbital region. Also there is hypovolemia, because of which the glomerular filtration rate will decrease, and when the GFR decreases, there will be increased in the levels of aldosterone, increased in the levels of renin, and there is a decrease in the secretion of the atrial natriuretic peptides. That leads to again increased sodium and water retention, and that will exaggerate the edema. So it is quite easy to understand when you understand the mechanism, how this all these things are happening because of the proteinuria. And also it is easy to understand that when there is proteinuria, there is also loss of immunoglobulins. When immunoglobulins they are lost, they will cause increased susceptibility to infections, and especially the staphylococcal and pneumococcal infections, they are seen more. Also, there is loss of anticoagulants like antithrombin 3 and protein C and protein S. So when these and natural anticoagulants they are lost in the urine, there will be increased tendency to of thrombus formation. So there is thrombosis and thromboembolism. So these complications are very common in the nephrotic syndrome, and also renal vein thrombosis can be seen because of this hypercoagulable state. So all of this, it is easy to understand. There is proteinuria, because of which there is hypoalbuminemia. Then because of this decreased colloid osmotic pressure, hypovolemia leading to decreased GFR, and because of this which there is increased sodium water retention and edema. And also when the colloid osmotic pressure is decreased, it directly causes the shift of the fluid to the interstitial space, causing edema. So um, you have to remember all these points in the pathogenesis of nephrotic syndrome. Also in Viva they ask why there are increased infections in nephrotic syndrome, why increased thrombosis. So again it is because of the loss of immunoglobulins and the anticoagulant proteins in the urine. Next important thing uh, that occurs in nephrotic syndrome is hyperlipidemia and lipiduria. So why does it happen? There is liver is trying to compensate for the loss of proteins, so it is synthesizing more lipoproteins. Now this leads to abnormal transport of the lipids. There is decreased lipid catabolism, and the lipoproteins they also leak across the defective glomerular filtration barrier. So the lipids are also moving out in the urine, causing lipiduria. So lipid comes out in the urine, lipiduria. That's why the nephrotic syndrome is also known as lipoid nephrosis. So lipid comes out in urine in the form of oval fat bodies and fatty cast. This I will explain a little later. And then there is hyperlipidemia because of all these reasons. So there is increased cholesterol, triglycerides, VLDL, LDL in the blood. Now next, what investigations can be done in nephrotic syndrome? So since it is minimal change disease, it is called so because there are no changes on the light microscopy. So it's also called nil deposit disease because there are no deposits seen in the light microscopy, and also on the immunofluorescence there are no immune complex or complement deposits. Now the changes which are seen, they are seen in the electron microscopy. So uh, on the biopsy, the electron microscopy can be done, in which there is diffuse effacement of the podocytes. So like the normal podocytes, they have the food processes lying on the basement membrane, but here the food processes they are effaced. So they are effaced, flattened, and they are also retracted. So they are also retracted from the basement membrane. So this is known as podocytopathy. The podocytes they are flattened, effaced, retracted, and swollen. So all these is causing the increased permeability. And podocytopathy, as you know, it is also seen in diabetic nephropathy, membranous glomerulopathy. So in all the causes of the nephrotic syndrome, in majority of them, the podocytopathy is seen. Now next, the hyperlipidemia is seen in the blood, and the another important point is urine microscopy. So in urine microscopy, there is nephrotic range proteinuria, that is more than 3.5 gram per day of protein coming out in the urine. Second most important point is the lipid coming in the urine. So lipid comes in the form of fatty cast. In fatty cast, the fat globules, they are attached to the hyaline cast. So the hyaline cast, it has this lipid globules embedded on its surface. It forms the fatty cast. And the other thing is the oval fat body. So what is oval fat body? The oval fat body, it is formed when these lipoproteins, which are filtered in the urine, they are reabsorbed by the tubular cells, the tubular epithelial cells, and then the tubular epithelial cells, they get detached from the basement membrane, and these tubular epithelial cells, when they come in the urine, then they are known as the oval bodies or fat bodies. So this is the mechanism of formation of the oval fat bodies, oval bodies or fat bodies. And when these oval fat bodies and fatty casts, they are visualized with the help of polarized microscopy, it is visualized or seen as Maltese cross. So this appearance, this is like a Maltese cross. So this is the characteristic appearance on the polarized microscopy. This is very often asked in the MCQs. So special stains that can be used to demonstrate these fatty cast and oval fat bodies. It is like Sudan black stain we can use for the demonstration of these fat cast, and oil red O is another stain. And lastly, the treatment, minimal change disease, it shows an excellent response to the corticosteroids, prednisolone, like prednisolone, and especially in children, they have a very good prognosis, and long-term prognosis of the disease is good, but relapses can occur. So that is all about nephrotic syndrome, and these are my reference uh, and upcoming topics. So if you have any query regarding these topics, you can put up in the comment section. Thank you very much.